Good afternoon, and welcome to today's caregiver webinar, Understanding Dementia for Caregivers. My name is Allegra Jaffe. I am a social service specialist with the Caregiver and Support Service Unit with Fairfax Area Agency on Aging. Before I introduce today's speaker, I will go over a few housekeeping items. Today's presentation is being recorded, and a recording and the slides will be sent to all the registrants a week from today. We are going to allocate a few minutes at the end of the webinar to go over your questions. So you can use a Q&A button at that time to ask your questions. Dr. Lawler, we have enabled closed captioning. If you would like to use subtitles, please enable closed captioning on your Zoom panel. And lastly, there will be a brief survey as you sign out. Please take a moment to fill out that survey because it helps us create programs that are relevant and important to our caregiving community. Now it's my pleasure to introduce today's speaker, Dr. Abigail Lawler. Dr. Abigail Lawler is a board-certified member of the American Board of Psychiatry and Neurology. Dr. Lawler is originally from Ohio, where she completed an undergrad at Ohio University and also studied abroad through Duke University in Costa Rica, where she completed a Spanish immersion program. She came back to Ohio for medical school at the University of Toledo, and then went on to complete her residency training in neurology at MedStar Georgetown University Hospital in Washington, D.C., where she served as chief resident. Dr. Lawler stayed at Georgetown University to complete a fellowship in movement and memory disorders, helped start the first ever Parkinson's and dementia clinic, and participated in baseline cognitive and neurologic assessments of retired NFL players for the NFL Players Association. Dr. Lawler is very well versed in treating many different neurologic conditions, but specializes in treating movement disorders, offering a wide variety of treatments options beyond traditional medical management for Parkinson's disease. Dr. Lawler also specializes in the diagnosis and treatment of a variety of autonomic conditions, muscle dystonia, as well as spasticity using botulinum toxin injections, as well as the various types of dementia. Dr. Lawler is very passionate about the care and treatment of patients with memory disorders. And after several years in San Diego, where she served as medical director with the Parkinson's Association of San Diego, in the fall of 2022, Dr. Lawler joined the Inova Parkinson's and Movement Disorder Center as their 5th movement disorder specialist and is creating educational programs for allied health professionals. So Dr. Lawler is going to share her expertise today with us. Thank you, Dr. Lawler, and welcome.
Thank you for having me here today. Let me get my screen going here. All right, so today's talk is really about understanding dementia for caregivers. We're going to go through a series of slides here and hopes you will have a greater understanding about what dementia is and how it affects patients and families. There are many types of dementia, but the main one we're going to focus on is the most common one, and that's Alzheimer's type dementia. So what exactly is normal aging? So normal aging, we experience minor changes in memory and thinking as we age. That is normal. In fact, you will often hear people describe it as things like, word finding difficulty, or what we call tip of the tongue type syndrome, where, patients they're in conversation with friends or family and they just can't, that word that they're looking for just won't come. Usually though, initially these changes don't affect daily functioning and people are able to live their lives normally and independently. Memory changes is a normal part of the aging process, as I mentioned. It's common to have recall problems at different moments, and be slower at remembering names and details. People often say, that show that was on TV the other night, and there's the actress, what's her name again? These scenarios play out quite commonly amongst people as they get older. Alzheimer's disease is not a normal part of aging, though, just to be clear. It's not just something that happens as we get older. It is a clear pathological process that's going on in the brain, and we'll get into more details about that. And so if Alzheimer's was a part of the normal aging process, then everyone over the age of 65 would have Alzheimer's disease, and that's just not the case. So what is normal aging? So forgetting part of an experience, forgetting something, but eventually remembering the information. You can still follow instructions without difficulty. You're able to use different compensatory mechanisms like notes or reminders. People will keep detailed calendars of their schedule to keep the, things aligned. They can still manage all their own personal care. That's dressing, bathing, grooming, feeding themselves. They're able to manage their own financing. Not normal aging is forgetting an entire experience, forgetting conversations, forgetting dates, and even with reminders, unable to recall information at a later date. So you're in conversation, you forget the name of someone or the title of a book or something you forget, but it comes to you later. Less and less able to follow instructions over time. Especially things that happen in a series are become more difficult, gradually becoming less able to benefit from memory aids like calendars and journals and, sticky notes and things like that. Those compensatory mechanisms stop really becoming effective, or the patient really forgets even to use these compensatory mechanisms, losing the ability to engage in personal care. So patients will become a little more disheveled. They don't stay on top of routine bathing. They may dress inappropriately. That's not fit for the weather, or they put clothes on the wrong parts of their body or backwards, a shirt on backwards. Unable to track spending, pay bills, and manage savings checking accounts, those kinds of things. So dementia really are different types of disease, by far the most common type of dementia. They're also with bodies, which is really a subtype of Parkinson's disease. And then there is Parkinson's disease related dementia. So patients with regular Parkinson's in the later stages of the disease can start to develop a type of dementia. There's Pick's disease, also known as frontotemporal dementia. And then there is a frontal lobe dementia specific. There are other things, though, that can cause cognitive changes or changes in memory. And some of these diseases listed here that, but these diseases are very, very different than dementia, and they all have different hallmark features to them. They are things that we screen patients for, and taking a good history and the story from the patient and the family on what's going on. And the time course also matters, the onset of the disease, how long it's been going on for, and how fastly it's progressing really can help differentiate a lot of these different types of disorders out. Most of these diseases listed here are much more rapid in terms of progression. But again, we do screening blood tests that would pick up a lot of these, or definitely an MRI of the brain that would catch some of these different types of diseases. And physical exam, would there be findings on physical exam for a lot of these different diseases listed here. One important thing I like to point out is that depression and anxiety can mimic dementia. In fact, you can have quite significant cognitive problems and changes with memory, short-term and long-term, with uncontrolled depression and anxiety. And when we think that depression and anxiety is the underlying cause of the cognitive disorder, we call it pseudo dementia. So that would be another sort of type of dementia, but it's not a neurodegenerative condition. It is basically a mimicker of depression. And then we have all the toxic metabolic type things. So people that have problems with drugs and alcohol, heavy metal toxicity, and different types of organ disease type problems can lead to memory disorders, vitamin deficiencies, and then, side effects of multiple medications. Today's patients, they're on multiple medications, and many of them to control various different chronic illnesses, and all medications have side effects. So that also, and some of them are centrally acting, and they can affect cognition. So definitely review of medications is warranted, anyone coming in for memory evaluation. So Alzheimer's disease is also known as senile dementia of the Alzheimer's type, or simply Alzheimer's. It's the most common form of dementia, and it is an irreversible progressive brain disease that slowly destroys memory and cognitive function. It's characterized by impairment of memory and eventually by disturbances in reasoning, planning, language, and perception. The risk of developing Alzheimer's increases with age. However, in most people with Alzheimer's, symptoms first appear after the age of 60. I will say, though, for me, when patients come in with family and the patient does not themselves think that they have much of a memory problem, but the family is noticing more issues, that's more of a red flag than the patient that comes in by themselves and is noticing changes and thinks that they have a memory problem. Because usually, not always, but usually, one of the things that happens in these different types of dementia is that the patient starts to lose insight or their ability to even know kind of what's happening. So they may not recognize that they're having any issues until it's brought up to them by family or friends. So that's an important distinction too when we're doing these evaluations. So the hallmarks of Alzheimer's disease is what we call these plaques and tangles. This is a pathological process that's going on in the brain. The brains of people with Alzheimer's have an abundance of these two types of abnormal structures. So beta amyloid plaques, which are dense proteins that are deposited in the brain, and they accumulate outside and around the nerve cells. And then these neurofibrillary tangles are also twisted fibers that build up inside the nerve cells. So these are things that can be seen in postmortem autopsies of the brains of patients with Alzheimer's. And we also have ways of scanning the brain and seeing deposition of amyloid. There is something called an amyloid PET scan that can look for amyloid deposition in the brain. However, I will say right now that test is only available if patients are in a clinical trial. It is not something that is a covered study by Medicare or any of the insurance plans right now. We have other tests though, and we'll get to that. Here's an example on the left of a normal neurons that are in the brain. So they have these little synapses that make connections between cells, and it allows information to travel and communicate from one part of the brain to the other. In a patient with Alzheimer's, the neurofibrillary tangles are inside the neurons, disrupting normal processes within the cell. And then the amyloid plaques, they are in between the cells, which are disrupting the communications between the cells. So there are various stages of disease with Alzheimer's dementia and the various other parts of other types of dementia. In the earliest stages, these are the highlighted blue areas are the areas or parts of the brain that are primarily affected. As the disease progresses, you can see that other parts of the brain become affected. And that's when we also see a decline in how patients are able to function on a day-to-day basis. So as Alzheimer's progresses, the neurofibrillary tangles, they spread throughout the brain, and the plaques also spread throughout the brain, starting in the neocortex. And the final stage, damage is widespread, and actually the tissue starts to shrink or atrophy. And that is something that we screen patients for. There is a specific type of MRI of the brain that we do. It's called volumetric analysis, and we are actually measuring different volumes of the brain. And the reason why this is important is because, as we mentioned earlier, the brain does shrink as a normal part of aging, but it also shrinks to a greater degree in some of these different types of dementia. And so what we want to do is, when we're looking at somebody's brain, we want to be able to determine if the amount of shrinkage that's there, is that normal for the patient's age, or is there something more advanced going on? And also we pay attention to what parts of the brain are more affected by the shrinkage or the atrophy. And that can give us a clue or a tip off to what type of dementia it is and how far into things are we. I will say, though, there is no direct correlation with severity of disease and degree of atrophy. It used to be a thought that there was a direct connection there, but there isn't necessarily. And I've seen this play out in the real world too with patients, where some of them actually have what is deemed normal brain volumes for their age, but yet they have significant mild to moderate dementia. And where that comes into play, or why that is that sometimes you could be born with, let's say, brain volumes in the upper 80s or 90th percentile for patient age. So well above average for size of brain. And then maybe it degenerates to 50 or 60th percentile, or maybe 35th percentile. So it's degenerating, but it's still in the normal range. And so if I'm doing a spot check and I'm seeing someone's brain for the first time, I don't necessarily have anything to compare my study to. So I don't know if this is normal for the patient. All I can say is it's normal for their stated age. And so sometimes it's, important to pay attention to that sometimes our studies, they help us, and sometimes they provide information that doesn't necessarily help with diagnosis, but oftentimes MRIs are very helpful at making sure there aren't other underlying causes for the cognitive changes that we're seeing. So pathophysiology, this is just a cross-section of the brain detailing some of the structures where the memory center lives. So the temporal lobes, I don't know if you can see my arrow or not, but the temporal lobes are on this lower medial aspect of the brain. And there is something called the hippocampus, which lives in this temporal lobe. And in this half of the brain, you can see is much smaller. So the ventricle, which is a normal space in the center of the brain, is enlarged. And the tissue, this is enlarged because the tissue is shrinking. It's shrinking away, making this space here look bigger. And the temporal lobe is almost non-existent, right? It shrinks away to almost nothing. And that's where the hippocampus lives. And that's the memory center of the brain, or the hub of where memories are generated and stored. Language is not too far from there. So language is in this area of the brain here. And in this Alzheimer's patient, you can see that also is very shrunken. This is just a gross pathological picture of a real brain. And you can see the space, or these gyri, are widened between the tissues. And it's because the tissue itself has shrunk and the space between the gyri are larger. So causes, the known genetic causes of Alzheimer's disease are on the left side here. There are some known chromosome abnormalities, but they're only responsible for a very small number of the total cases. It's rare when we see actually a genetic form of dementia or Alzheimer's. Usually it's a combination of environmental exposure, your genetics, and part of the normal aging process. It's sort of like the perfect storm, if you will. The environmental factors that can play a role are things like toxins, viruses, prions. Now that's a specific thing. Low level of education. So we do see people that come from educational backgrounds that are much lower, and economic status. They have a higher incidence of dementia. And then, so there's something about education that's a little bit neuroprotective. And then head trauma. So concussions of any kind, especially recurrent concussions, can lead to that pathological process that starts the Alzheimer's disease. And that goes back to that other thing that we are learning more and more about these days called chronic traumatic encephalopathy. So it's a pathological process that starts in the brain related to recurrent concussions. So Lewy body dementia, again, I mentioned earlier, this is a subtype of Parkinson's. And the difference between Parkinson's disease and Lewy body disease, or Lewy body dementia, is that Lewy body patients, in order to meet criteria for a diagnosis of Lewy body dementia, you have to have developed significant cognitive problems within 2 years of developing motor symptoms. And the motor symptoms can be different things. It can be a tremor, but it could be other gait balance abnormalities. Versus regular Parkinson's disease, they don't start developing memory problems related to their Parkinson's until a minimum of at least 8 or 10 years after being diagnosed. So 30% of all dementias encompass Lewy body dementia. That's probably wildly too low, though. I bet it's higher than that because there's a lot of people with Lewy body that go undiagnosed. And it's only second to Alzheimer's, 1.4 million people affected. The classically associated with an early cognitive change within 1 to 2 years of PD symptoms, Parkinson's-like symptoms, more relatively rapid in onset and progression. They have fluctuating cognition, meaning so sometimes they have good days and sometimes they have bad days. It's not that every day is bad. They have visual hallucinations. They may see or even hear things that aren't there. And they have Parkinsonian features. So stiffness and slowness of movement, sometimes tremors, balance problems, maybe a shuffling gait, walking problems. They are very sensitive to the Parkinsonian type treatments. So whether that's replacing dopamine or other neuroleptics can cause a lot of side effects. So these patients have to be very carefully started on medications in the right order. And then REM sleep behavior disorder is now part of the diagnostic criteria for Lewy body disease. And that's where you act out your dreams, you talk in your sleep or move in your sleep when you should not be. So Parkinson's dementia, again, it's basically dementia related to the Parkinson's disease itself, but it's much, much later in the course of the disease. So diagnosis is typically made by a combination of things of taking a good thorough history, especially from relatives and family. It's always better to have that outside collateral information. Clinical observation based on the presence of characteristic neurological and neuropsychological features and the absence of alternative conditions, right? So we're screening patients for other health problems that could explain why they're having the symptoms they're having. And then we will use advanced medical imaging like CT or MRI. MRI is the best modality, especially a 3T type MRI with volumetric analysis or neuroquant. And then sometimes we will do a SPECT scan or a PET scan to exclude other types of dementia and other types of brain problems. And the PET scans, the glucose or FDG PET scans are so good now that sometimes based on the pattern of hypometabolism that we see, we're able to differentiate different types of dementia there. The diagnosis can be confirmed also with, a very good postmortem brain biopsy. So looking at the histology of the sample of brain tissue, but, that's not often done. So we will do different types of neuropsychological testing in the office. The mini mental status exam is a nice quick screening tool. I more often will use the Montreal Cognitive Assessment because it is a little bit more sensitive at screening patients. The mini mental is just in some cases almost too easy. So patients can do well on it and it doesn't necessarily help us identify patients that are starting to have problems. So we do that in the office for initial evals, but then we're often referring patients for more formal neuropsychological testing, and that's called neuropsych testing. And that really is a better tool to help with diagnosis. So psychological tests for depression are also employed. We screen patients for depression, and it's often common that you can have both together. But we just want to make sure that we're not, missing somebody that has pseudo dementia, like we mentioned before, which can be caused by underlying, depression and anxiety, which is a very different treatment plan and course for the patient compared to these other types of dementia. When available, we will use the neuroimaging, as we discussed, to confirm diagnosis of Alzheimer's disease. And then in patients that already have a diagnosis of dementia, we sometimes can help differentiate what type of disease it is, depending on some of these different brain tests and scans that we're able to get. And the other thing that's not on here, which I need to update my slide, is that we are now able to diagnose Lewy body dementia and Parkinson's disease by doing a simple skin biopsy. So here is one of those brain scans. This is a PET scan on the left of a normal brain. So we see all the beautiful bright colors that tells us that the metabolic activity is normal, the brain is active, there's lots of things going on. And then this on the right is the scan of an Alzheimer's disease brain. You see a lot of purple, which is decreased or hypometabolism, not a lot of activity going on. It's more quiet. The analogy I usually tell patients and families about this test and how it's helping us is that a normal brain is kind of like a house. Every light should be on in every room of that house in a normal functioning brain. In patients with Alzheimer's disease or even some of the other types of dementia, one room or two rooms, the lights might be off. So it's just decreased activity which is a sign of hypometabolism in different parts of the brain in these different types of dementia. So treatment is mostly pharmacologic, so different types of medications. So here are the different classes of medications. Acetylcholinesterase inhibitors, those are the most commonly prescribed first-line treatments, but we also often will pair them with one of these NMDA receptor antagonists. We also use a host of other medications to treat all the associated problems that come with the disease. So antidepressants, anti-anxiety medicines, cholinergic type agonists, and the like here. These are medications that can alter mood, and we use them to help with patients that have different types of behavioral problems and patients with sleeping issues, and even patients that have problems with appetite. There's various medications we'll employ. So one of the misnomers, though, is that medications are used to delay or slow the symptoms of Alzheimer's disease, and that is just not true. None of these medications have the ability to slow disease progression. So that is a question that comes up a lot. And the medicines will lose their effect over time, and they don't prevent or cure any of the dementias. And then the question comes, well, why treat then? Why are we using these medications if they're not doing anything to slow disease progression or, really change the course of the disease? And the answer is because the medications have been shown to be beneficial to prolong people's ability to maintain their independence with their activities of daily living. So that is true. So they're not the greatest actually at improving memory, ironically, but they can improve quality of life by helping people maintain their independence. In doing that, though, the disease is still progressing at the same rate. It has not done anything to change the course of the disease or the progression of the disease, even though it may feel or seem that way. It's actually not. So Aricept donepezil is a pill. It's the most commonly prescribed. The Exelon medication is available in a patch or in a pill. I often don't use the pill because it has so many side effects, but the patch can be very beneficial. Namenda or memantine is another pill. It's twice a day, often paired with either the Exelon or Aricept. And then Namzaric is just a combo pill where they combined memantine and donepezil in one pill. And Razidine is an alternative acetylcholinesterase inhibitor. Sometimes I will get patients to tolerate that if they get side effects from one of the other types of medications. And side effect profile with all of these is primarily GI-related side effects, so nausea or diarrhea. We do start patients very slow and work up to a full dose to try to avoid that. So other things that we have to take into consideration is depression. So patients often get depression and anxiety. These are some commonly prescribed medications for this. It can take up to 4 to 6 weeks to work, though. Sometimes they can also help people with sleep. Some of the other medications that we will use are for hallucinations or psychosis. So Nuplazid is very effective. That also can take up to 4 to 6 weeks. Sometimes we will use Seroquel or quetiapine because it works quicker, but Seroquel tends to have more side effects. It can be more sedating. So sometimes I will temporarily use it and pair it with Nuplazid and then eventually get rid of the Seroquel. And then we have Remeron, which is used for depression and anxiety, but it's also used to help patients with sleep. It's also a good way to help stimulate appetite. Other mood enhancing medications. So Depakote is commonly used for patients that have more aggressive type agitation behaviors. We can use other medications, Trileptal and Tegretol as well. These are classically anti-seizure type medications, but they really can have a very nice calming effect on the patient. So hallucinations and delusions. So patients will often complain about seeing or hearing or feeling things that aren't there. Sometimes you can see patients reaching for objects that aren't there or talking to, relatives that have been dead for years. Hard to know sometimes if things are really a delusion. So it's a thought or a belief that something is happening and it's not, versus actually seeing or hearing something. That's the difference. And then illusions are you actually a real object in the room, but maybe it's a dimly lit room and it's a pile of clothes on a chair, and across the room it looks like a lion sitting there, and you get close and you can see it's a pile of clothes. That's an illusion. Not that important of a distinction, because all of these things can happen in the different types of dementias and fall under the umbrella of psychosis. So medications to avoid. So avoid medications that block dopamine or acetylcholine. So there are a number of medications that are prescribed for chronic illnesses or even over-the-counter remedies that are used to treat common cold. These medications can be centrally acting and can cause problems with cognition and memory. So neuroleptics or antipsychotic type medications are altering, neural pathways in the brain and can affect cognition. Cold medications that contain dextromethorphan, like your Robitussin DM, the DM stands for dextromethorphan, can affect cognition. Anti-nausea medications can affect cognition. And older Parkinson's medicines like Artane are not great for patients with dementia. So the only diet that we typically talk about recommending, because I get this question a lot about, well, what, is there something with the diet we can do to change? There's never been really an associated specific diet for dementia. There's the MIND diet, which essentially is a Mediterranean diet, but it's plant-based foods and foods that focus on improving or increasing healthy fats, such as olive oil and canola oil. But there's no direct correlation with eating this diet and improved cognition per se. It's just that this is the healthiest diet that we know of that's out there. And it's recommended that, we try to follow a healthy diet, because if you follow an unhealthy diet, you're going to be causing other health problems, which could be exacerbated and then in turn secondarily affect cognition. The ketogenic diet has fallen into favor recently. And a combination of a Mediterranean ketogenic diet is thought to be helpful. Ketogenic just essentially means low carb, moderate protein and high fat, kind of like the Atkins diet. It forces the brain to use an alternative source of energy as opposed to glucose. And that has been shown to actually be helpful with cognition. And there's also a lot of people that have food intolerances to carbohydrates. So a lot of people have gluten sensitivities. And so sometimes making these diet changes can make a difference. Routine exercise is recommended, but as tolerated. We don't want people to start a marathon regimen, but getting yourself active and mobile and out there, fresh air, moving, the stimuli of the environment rather than being a couch potato is preferred. Getting good sleep, of restful sleep per night, 8 hours a night is recommended. For people that aren't getting good sleep, that really can cause worsening cognition and memory. So we always try to work on people that have sleep problems and how can we improve sleep, and also treating underlying sleep disorders. So people that have sleep apnea or REM sleep disorder or insomnia for a variety of different reasons, we work on sleep hygiene and fixing these underlying disorders so we can get better sleep. And keeping your brain active. So sometimes patients will retire and they say everything went downhill after retirement. You don't have a purpose to your day anymore. You don't have appointments or schedules to follow. So then you sort of lose track of time. There's other things you can do though. You can volunteer. You can stay engaged with, activities, keep yourself involved, and not just, things like reading books and watching TV. Play games, card games that allow you to think critically and make decisions about things. That's using your brain. Even luminosity.com is a great tool for brain teasers and quizzes and games that you can use to challenge yourself. And then we always talk about people thinking outside of the box, right? So doing things out of your comfort zone. So maybe you're not artistic, but you decide you're going to take a painting class. Or maybe you're not athletic, but you're going to go to the YMCA and take a pickleball class or something. Do something different so that it gets that brain working in a different way that it's not used to. Because you want to get yourself away from using your compensatory mechanisms, right? The things that are the tried and the true that are in the long-term memory. You want to get that short-term memory active. Keep a daily routine. Routine is definitely important to kind of keep your world intact. And I stress that for family members when they're caring for a loved one that's got a dementia type process. Keeping a routine will keep things, reduce stress for the patient and keep things more easier for them to follow if they know what to expect. And then family support is key. So, getting an early diagnosis and treatment is only important from the standpoint of knowledge is power and knowing what to expect and being able to plan for patients that are living independently and maybe they do or don't have a lot of family around. They can plan when we know what the diagnosis is. Definitely getting evaluated by a neurologist who's trained in memory disorders and movement disorders is key because there is a lot of overlap between movement disorders and memory disorders. I've seen many, many patients get diagnosed with Alzheimer's dementia by someone else. And then I see them and they have Parkinson's or Lewy body or something. About is important. There are a number of things out there, homeopathic, and I'm always open-minded about discussing these options. Want to make sure people are not doing things to hurt themselves. And there is, the supplement world out there is $1 billion business in terms of memory. There's tons of things that are out there and they're expensive and they may not have been studied in clinical trials. So definitely you want to bring up any supplements that you're trying with your physician. But the multidisciplinary approach is best. That's where we see the most success. So it's not just anyone, cook in the kitchen. You've got a neurologist that's working with a psychiatrist, PT and OT, nutritional support groups, going to a wellness center where a lot of these things are facilitated activities for patients specifically with different types of dementia, and lots of family and friend support is always very helpful. You can't do it alone. It takes a village, as they say. So care for calm will say that common that patients will repeat themselves. And I try to stress the importance that one thing you need to realize is that it's not your job to point out that they just said that. You should probably, choose strategies to just overlook that they've repeated themselves 3 or 4 times, or this is the second time or third time today you've heard them ask that same question. Because if you bring that kind of stuff up, it's really not helpful. All it does is it worsens stress and anxiety for the patient. And the other thing to note is that these patients have trouble learning new things. So if they're stuck in their routine because their routine works, help keep their day intact and helps them stay calm and knowing what to expect, try not to switch up the routine because you're going to see a lot of problems by doing that. And then other examples that I like to give for patients and family is this, for example, I had a patient years ago, a grandfather who was living with the family, and he had a tendency to leave the back door open, and they had a cat or a dog, I can't remember which. And the cat would get out and it would cause, all these family issues. And they kept telling him, don't forget to close the back door, close the back door. So I told them, rather than mentioning that to them, you see the doors open, just close it. There's no point in mentioning it to grandpa because he is not going to be able to, remember that. And he's going to do the same thing again tomorrow. So rather than cause the fight, the argument, the stress, the anxiety, it's better just go with the flow, have an understanding that we have to come up with a different strategy for the safety of keeping the doors closed, and that telling grandpa is not going to be helpful. And getting patients' families to realize that can really change the dynamics in the household quite a bit, and reduce fights, which can happen. Don't argue or try to convince the patient that, X, Y, and Z is happening when they believe A, B, and C is happening, because you're never going to win that battle. And again, just causes stress and anxiety. Acknowledge their requests and respond to them is important. They don't want to feel like they're being blown off, or that what they're asking about or what matters to them doesn't matter, because they'll be able to pick up on those cues, and probably even the cue from you that, oh, this is like 10th time they've asked me this. Just try to be patient, and and then we can come up with strategies to help them if they're asking the same question over and over, right? So compensatory strategies are key. Centralized calendars and journals and things like that are very important. And try not to take stuff personally. So I have seen personality changes in patients where they almost regress to being childlike. And the children of the patient are now having to become the parents, so to speak. And this dynamic can really take a drastic turn on multiple levels and cause a lot of arguments and things like that. And people say things they don't mean. So you can't take it personally, because the person who is living with the dementia process, they are not themselves anymore. And the them who they used to be is not them anymore, unfortunately. And so you can't take the things that they're saying personally, because they don't even see the family members anymore in the same light, in the same way. And sometimes that doesn't even become apparent until the patient stops being able to recognize their family members. That process of not understanding and knowing who their family are starts long before they lack their ability to recognize and identify who their family members are. So just know that they may not see you the same way they used to. And remember, it's the disease talking, not your loved one. So they may say things that are hurtful. And oftentimes it's best just to redirect, change the topic, and try not to take it personally. So caregiver support programs and services are key. There's a couple different resources here, and then just having each other is really key. You and your family will understand each other better, and knowing what you're going through with the patient that has the dementia more so than people that aren't in your home, dealing with it on a day-to-day basis. I try to get a snapshot and an idea of what's happening in the home by asking questions in different ways. It's not uncommon for family members to write me a letter. They maybe don't want to discuss everything that's happening in front of the patient. So I will take the letter and read it on the side, and document the appropriate things. But it's important to know these things, but sometimes it is just too stressful to talk about these things in front of the patient, because they're going to get very defensive. They're not going to believe it. They'll be in denial, and it causes stress and anxiety. I had one patient, we had to do telemedicine, and essentially, the patient was in the house, but she was not necessarily in the room. And I was on the phone, with the family, because every time she came into the office, the blood pressure would be like 200, she was like on the verge of having a stroke, because she got so mad and angry at the thought of someone accusing her of having, memory issues or memory problems. So just take that into consideration, that we have other ways of doing the visits if coming in the office and talking in front of the patient is too difficult. So contact us, reach out to us if you have questions or concerns, or just want more information about how to navigate this new life with dementia. I will say it is a rapidly growing disease in terms of the frequency that we're seeing it in the community. And that has to do with the fact that in the United States, our population is aging, and we now are entering into sort of a new world where our population is now the majority of our population. We have a larger population over the age of 65, 70 years old than ever before in history. And because there's so many people in that age bracket, we are seeing more and more of these dementias being diagnosed. So it's essentially a new pandemic that's coming of neurodegenerative conditions. And there are a lot of institutions around the country that have recognized this, and they are preparing in different ways for the volume that's coming. And we are already seeing it. It's taking over practices all over the place. What's becoming harder and harder is that there aren't enough memory care centers for patients to go to. We try to get patients to live in the home for as long as we can make that happen. I'm always a proponent of pushing living in the home for as long as possible, because that's people's comfort zone, right? It's where they're most comfortable. That's where their routine is. They have familiarity with their surroundings. Anytime that gets disrupted, we see decline and changes in the patients and how they do. So, but sometimes circumstances are what they are, and we have to, have patients move into a memory care unit. So, for either safety reasons or just they don't have the support or the financial means to hire, help to come in 24/7 to live in their own homes. So there's a number of reasons why social situations are that they are, and patients need to live in different settings, but always a proponent of people staying in the home for as long as possible.
Thank you so much, Dr. Lawler. That was an excellent presentation. And at this point, I would like to invite our audience to submit their questions. You can use the Q&A box and I'll read them out loud. So we got a few questions that came in, Dr. Lawler. And the first one is, are certain long-term medications linked to an increased risk of dementia?
Yeah, so this has been looked at. I think the question I get a lot of people asking about is about statins or cholesterol modifying medications. So those type of drugs, it once was thought that there was a link between the use of statins and increased incidence of dementia, and that's actually been disproven. So patients that need to be on statin therapy because they have high cholesterol or high triglycerides or whatever it is, or they have a history of stroke and they need to be on cholesterol medicine, should really be on it if they need to be on it. But there's not really been a link to that and dementia. But there is one controversial class of medications, and that's opioids. So opioids are toxic to the brain. So it's definitely not a good thing. It's toxic to the brain. Same thing with other types of street drugs, and alcohol is also toxic to the brain. So you're definitely increasing your risk to have a dementia type process by, using these types of things. But there are a number of patients out there that are on chronic opioids for different reasons, and their life is what it is, but it is toxic to the brain, even at low levels. The other one I get is benzos. So benzodiazepines, which are the anxiolytics or anti-anxiety type medications, depends on really the dose, is what I would say. So low doses used sometimes for sleep or anxiety at night, I would say no, but higher doses or patients that need to frequently change the dosing of their benzodiazepines and are taking it throughout the day for anxiety, there is an increased risk of that and the dementias.
Okay, thank you. What can be done earlier in life to prevent or prolong the onset of dementia?
Well, not a whole lot. Usually by the time, people start presenting with symptoms, the wheels are already in motion. So, and it's something from your past, right? So remember we talked about that. There was the slide about genetic influence and then environmental factors. It's sort of like that perfect storm. Something usually has already happened, toxic exposure of some kind. So, minimizing toxins, I would say, would be one thing, but a lot of times we don't know the source or where it's coming from. If you live in an area that's used to be farmland and you live on a house that has well water, you can have your well water tested, for pesticides, insecticides, that kind of thing. But if you've been living there for years and you've been, immersing yourself in that water for years, it's probably too late. So whatever it is, it is. But known toxic exposures, I had a family of they were dry cleaners, and they had a lot of dry cleans. Another one was a carpet cleaning business. So, but these are the people that are actually doing these jobs. not people that have their carpets cleaned in their house and, are walking on the carpet necessarily. Unless you're getting your carpets cleaned professionally every week, I don't think the exposure would be, enough. But paint, so people that were professional painters or artists that and a lot of exposure to blood, paint thinners and chemicals and different types of art type paints and things like that I've seen a link to. So just think about the toxins in your environment. I wouldn't say you need to get extreme and do everything organic and drink only bottled water. No one's proponent of that. Again, it's usually a perfect storm. So it's a combination of your own genetics and some sort of environmental trigger,
Is there a link between seizures and dementia?
No, not necessarily, but I will say that patients with seizures, especially if they're not well controlled, do have cognitive changes and lapses in memory related to the seizures themselves. But people that have epilepsy don't have necessarily an increased risk of dementia.
Can unresolved grief or PTSD be a factor in diagnosing dementia/Alzheimer's? Can therapy still be effective if so?
Yeah, I mean, so anyone who has underlying psychiatric illness of any kind, that can play a role in, we try to resolve those issues or treat those issues and kind of see if there's been any improvements in cognition. But we have other ways of, differentiating dementia and people that have cognitive problems related to underlying psychiatric illness. Patients have psychiatric illness is different. I don't know, things when we're testing different parts of the brain and doing different types of tests, there's a pattern that we look for that helps us differentiate the two.
Thank you. I've heard about caregivers talk about stages of dementia, example, stage 5. What does that mean? How do we know what stage our loved one is in?
Yeah, I try to get away from the staging because it doesn't have a whole lot of meaning either, because patients can live in a stage for years. And what affects disease progression is how healthy you remain. So in general, most of these dementias are slow in terms of progression. Most of them. Alzheimer's is the most common. I like to use that as a good example. So they kind of smolder in the background. As long as you remain healthy and you don't get sick with colds or flu or COVID or need surgery for something, or, those would all be considered major stressors that you could see a decline in cognition. And sometimes after they get over the stressor, patients don't fully go back to their baseline. They may achieve a new baseline and never, totally go back to their old baseline. But that can affect disease progression. So we try to tell patients, just try to remain as healthy as possible. Just be smart, proper hand washing, someone's sick, just, don't go around them. I know sometimes it's hard with holidays and family gatherings and people feel pressured to, be around loved ones. And now that we are post COVID pandemic, we all live our lives a little differently today than we used to in terms of, communicable diseases like colds are treated way different than they used to be, because we're all worried, is that cough a cold or is that cough COVID, so proper hand washing is the key. And, wearing a mask when in public, or prior, as far as knowing what to expect and what stage their family member is in, it doesn't really have much relevance or importance. But there's 3 main stages is what I would say. Some of them get lumped together, like 1, and then 2 and 3 are kind of lumped together, and 4 and 5 are lumped together. So it's early, mild to moderate, and moderate to severe is kind of how it is. And again, as you're progressing through the stages, you're losing more and more of your independence and your insight. Initially, short-term memory is affected, and eventually all memory is affected, short and long-term. In the later stages, you can't really know who are, let alone who family members are. You're not able to identify as people that. And then in the end stages, patients really stop eating and drinking, and that's kind of where things start to really fall off, because, dehydration, you really can't live long without drinking water. Patients can be prompted to eat and drink, but sometimes in the later stages, the food goes in the mouth and they really don't know what to do with it, right? They kind of mill it around and it just takes forever just to eat a single meal. So if you're not getting that nutrition, we see a lot of dramatic weight loss, but it's the dehydration that will send patients into the ER. You'll see a little more rapid decline when they get dehydrated. It increases their risk of urinary tract infections and all of that. So there's things we can do. Certainly, if you want to prolong someone's life for as long as possible, doing some things on their own, the eating and the drinking thing, trouble. Sometimes we'll do mobile IV clinics once a week or once every 2 weeks, just keeping people out of the hospital. Hospital is no place to go. It's just for a variety of reasons. It's rare that I see family members reach for, tools like feeding tubes and things like that. But there are ways we can take care of those problems.
Okay. How do you bring up gently with your loved one to get tested if you suspect there's an onset of dementia?
That is really hard. I've certainly seen patients show up and not know why they're here. That has happened many times. And it's, the family has coaxed them to go see the doctor, but they didn't really tell them what it was about. But I think too, getting the family doctor involved, the primary care doctor, to start that conversation. Like, hey, I think they're starting to have a memory issue. Do you think we could they'll do screening quizzes in the office, the mini mental status exam. And it's taking sometimes the suggestion of the primary care doctor to go get for the patient to go get evaluated. So it's just a team approach. But it's touchy because I know patients will get very defensive and angry when they get accused of something going on with their memory. So, and another way is just rephrasing it, right? Say, I've been doing a lot of reading and I've heard, dementia is becoming more common and it can be genetic and inherited. And I want to know more about our family, health history. And for those purposes, do you think you could get evaluated? Hey, I'm thinking about, I'm going to get a memory quiz done too. It's just something that it's phrase it a little different. So it gets them in the door. And then, once they're here, we have ways of talking to patients and making them feel comfortable. And that this is just a routine screening. As we get older, people start to forget names and things like that. And we'll walk the patient through it with the family. And I can tell, with most patients, we got to be a little bit careful about, the words we choose and the phrases we use.
To continue on with that question, after you speak to the primary provider, like you mentioned to start with, is the next person a neurologist or a psychiatrist to speak to?
Usually neurology, oftentimes primary care doctors are pretty good. They'll prescribe antidepressants and things like that if they think there's an issue with mood. But usually neurology first. And then if we do the appropriate workup and we determine that this really is a psychological problem and not an underlying neurodegenerative process like a dementia going on, we will often refer them to psychiatry if they don't already have that relationship.
Are there any drugs in the pipeline to cure or prevent dementia?
Lots of stuff in the pipeline. Now, whether these are curative things or things that can slow disease progression is a different story. That's I could probably talk 2 hours on where we went with research and the memory disorders and where we are now. There's two schools of thought. One is focused on prevention of forming these tangles and plaques, right? When we're talking about Alzheimer's dementia. Another school of people are focused on, have the plaques there, how to get rid of them. They're developing treatments to, attack them and remove and clean out all the tangles in the plaques. And so there's different schools of thought as to why one is beneficial and one may or may not be beneficial. I will say that earlier intervention is key for some of these newer drugs that they're trying to develop. It's not effective in later stages. And I think a lot of the clinical trials that have failed over the years we've learned from them that you have to choose your patient population very carefully. Who you enroll in the trial can make or break the trial. If you enroll a lot of later stage patients that are too far advanced, your drug, I don't care what it is, it's not going to work. So there's just too much brain damage at that point and too much atrophy. You can't bring back, brain tissue will not regrow. Once it's gone, it's gone. So, it's hard to say what is the right answer, or a combo effect really is the right answer of cleaning out some of the amyloid that's there, and then maybe tackling the upstream problem that's causing these proteins to form in the first place.
And lastly, Doctor, a few people wanted to know, are you accepting new patients?
Yes, I am. Actually, I am. So I've not been here at Inova for very long. Came in the end of November, early December. So I am accepting new patients. So you could call the main Inova neurology number. Right now, I'm working out of the Inova Fairfax office. I also do telemedicine on Mondays and Tuesdays. But I think eventually Inova is opening a brand new big office in Ashburn in the Loudon hospital there. And eventually that's where I'm going to be based out of. But, I will say that finding the right person to kind of take you through this journey, because it is a journey, is key. And you want someone that you can talk to and feel comfortable with, and that is going to level with you, and, not be promise, the world, but also, be realistic, and but in a calm and comforting way, because I think that bedside manner means a lot to people and families, and this is rough. This is a hard diagnosis to get, and certainly a hard one to navigate, even with all the support in the world. It's difficult.
Yeah. Well, I thank you so much. We couldn't get to everyone's questions, but we are at the end of the hour and the presentation. Thank you again, Dr. Lawler, for sharing your knowledge and your expertise with us today. Thank you to our audience for making space to be with us today. We really do appreciate your time. And a quick reminder to please take a moment to fill out our survey. Those answers will help us provide topics and programs that you're interested in for the future. And we will be having our first health and wellness session, which is Come to a Memory Cafe, Friday, March 24th from 12 to 1. And our next caregiver webinar will be about the top 10 legal facts that family caregivers need to know, but probably don't. And that's on Wednesday, April 19th from 12 to 1. So I hope you can join us then. And I want to thank you all again. And I hope everyone has a great afternoon. Thank you. Thanks again, Dr. Lawler.
Bye-bye.
Bye-bye.